Okay, let's talk about one of the biggest challenges we face in anesthesia, taking a patient with pulmonary hypertension through non-cardiac surgery. It's a high-stakes situation for sure. So what we've put together here is a standardized, evidence-based pathway to help navigate it.
First, let's just lay out why this protocol is so important. The stakes are incredibly high. For elective surgery, patients with pulmonary hypertension can have a 30-day mortality rate as high as 18%. But look at what happens in an emergency. That can shoot up to 50%. And the adjusted odds ratio for mortality, it's a staggering 44.7. You heard that right. And here's the kicker. Most of these deaths happen within the first 72 hours post-op, usually from acute RV failure. This is exactly why we need a rigorous, structured plan.
So here's how we're going to walk through this. We'll follow the patient's journey, starting with preoperative risk, then medication management, the core principles inside the OR, what to do in a crisis with acute RV failure, and finally, getting them safely to post-operative care.
All right, first things first, formal risk stratification. You have to know what you're dealing with. This step is going to dictate everything that follows, your monitoring plan, your choice of anesthetic, and where the patient goes after surgery. This is the framework we use to sort patients into low, intermediate, or high-risk categories. As you can see, it pulls together a bunch of data points. Clinical signs like their WHO functional class, key biomarkers like NT-proBNP, and, really importantly, echocardiographic findings. We're paying close attention to RV function here, specifically something called TAPE-C, or tricuspid annular plane systolic excursion. This initial assessment really is the foundation for our entire plan.
You know, you really can't overstate the power of TAPE-C. A value under 18 millimeters is a huge red flag. Just think about this. For every single millimeter drop below that 18 mark, the patient's mortality risk goes up by 17%. That one measurement is an absolutely critical piece of this puzzle.
Okay, let's move on to medication management. The guiding principle here is actually really simple. Do not stop any of the patient's baseline pH-specific meds, period.
Let me be perfectly clear about this. Stopping these medications is not an option. It's a Class 1 recommendation to continue them. We're talking life or death, especially with the prostacyclins. If you abruptly stop those, you can trigger fatal rebound pulmonary hypertension and total cardiovascular collapse, sometimes within hours. It's non-negotiable.
This table is a really handy tactical summary of the common oral agents. You want to pay attention to the half-lives because that helps you plan for any potential missed doses. And look at the critical perioperative considerations. Things like not giving PDE5 inhibitors if the patient is on nitrates, or figuring out a bridging strategy if someone on an oral prostacyclin like selexipag has to be MPO for a long time.
All right, now we're heading into the operating room. The key here is to be proactive, not reactive. Our management is built on a framework that's all about maintaining hemodynamic stability for that very fragile right ventricle.
Every single decision you make intraoperatively has to support these 4 hemodynamic pillars. We have to prevent any rise in pulmonary vascular resistance. We've got to maintain systemic vascular resistance to keep that right ventricle perfused. We need to be ready to support RV contractility, and we have to be meticulous about optimizing preload because both too little and too much volume are tolerated very, very poorly.
When you're selecting your anesthetic agents, etomidate is often a great choice because of its hemodynamic stability. Slowly titrated regional techniques, like a carefully managed epidural, can also be excellent. But look over on the right. Nitrous oxide is absolutely contraindicated. It directly increases pulmonary vascular resistance, which is the last thing we want.
Your ventilation strategy is also key to keeping PVR down. The goal is straightforward: lung protective ventilation. That means low tidal volumes, just enough PEEP to get the job done, and strictly avoiding hypercarbia and acidosis. Remember, both of those are potent pulmonary vasoconstrictors.
For vasopressor support, vasopressin is your first-line agent. Why? Well, its mechanism through V1 receptors boosts systemic vascular resistance without messing with, and sometimes even improving, pulmonary vascular resistance. On the other hand, a pure alpha agonist like phenylephrine is something you have to avoid.
So what if you need selective pulmonary vasodilation? These are your 2 primary agents. Both are fantastic, they work fast and wear off fast. Honestly, the key difference often comes down to what your hospital has and the cost. Inhaled epoprostenol is way less expensive than inhaled nitric oxide. Just remember, with both, you can get rebound pulmonary hypertension if you stop them suddenly.
All right, now we have to talk about the complication we all fear the most: recognizing and managing an acute right ventricular failure crisis. This is a fast-moving, high-stakes event, and it requires a response that you've already rehearsed and have down cold. The first step in handling any crisis is spotting it early. So what are those key markers, both on your monitors and from just looking at the patient, that tell you the RV is about to fail?
Here they are. Clinically, you're looking for a systemic hypotension. At the same time, your central venous pressure is climbing. Hemodynamically, a dropping cardiac index and mixed venous sat are really ominous signs. And if you have a TEE probe in, an RV to LV ratio greater than 1 with that classic septal bowing, that confirms your diagnosis.
Now, this is a critical and kind of counterintuitive point. When you see an acutely dilated and failing right ventricle, our instinct is to give a fluid bolus. But that's often the wrong move. More volume just makes the septal shift worse, which then messes up your left ventricular filling and drops your cardiac output even more. The correct response is often to reduce preload with diuresis.
The first 5 minutes are absolutely crucial. You need to announce a pH crisis to get all hands on deck. Tell the surgeon to stop, crank up the FiO2 to 100%, and get that systemic blood pressure secured with vasopressin to maintain RV perfusion.
Okay, next phase. Early escalation is a two-pronged attack. You're going to support RV contractility directly with an inotrope like dobutamine, while at the very same time, you're reducing the RV afterload by starting a selective inhaled pulmonary vasodilator.
If you're not seeing a response to those initial measures, you cannot hesitate to escalate further. This means adding a second, more powerful inotrope like epinephrine and, this is critical, activating the ECMO team for a consult. Thinking about mechanical circulatory support early is vital in refractory RV failure.
Getting through the surgery is only half the battle. A safe handover to postoperative care is absolutely critical because remember, that highest risk period for mortality is within the first 72 hours after the surgery ends.
All of your intermediate and high-risk patients need a mandatory ICU admission. This slide lays out the specific triggers, any hemodynamic instability in the OR, the use of advanced therapies like inhaled vasodilators, or baseline severe RV dysfunction. All of those require intensive care monitoring postoperatively. No question.
And that brings us to a final critical question for you and your team. A patient with severe pulmonary hypertension who needs emergency surgery could walk through the door at any time. Is your institution's crisis protocol established? Do you have inhaled nitric oxide or epoprostenol immediately available? And most importantly, have you actually rehearsed the response? In this scenario, preparation is everything.